aged care across the board is promoting person-centred care. So we're actually expanding on that, I suppose, initiative in getting staff to expand their skills and knowledge around person-centred care. If they improve their listening skills and their communication skills, it actually improves their confidence and competence in dealing with the emotional needs of their residents. The project aims, the overall aims, are to improve depression, the better management of depression and behaviours of concern associated with dementia in aged care. We're providing them with best practice guidelines which promote psychosocial approaches as the first line approach. So we're trying to minimise the use of medication, or we're actually trying to improve the use of what medications residents are on in regards to their depression and their behaviours. The training program actually provides some tools, like in the form of a simple checklist that is quite simple to use, that PCAs can use to identify symptoms of depression, and then if they tick 4 more on that simple checklist, then they can refer it on to their senior team leader, like as their RN, their registered nurse, to follow up with an assessment, and perhaps the need for referring on to an external consultant such as a GP or a psychologist, or some of the extra consultants that aged care use, such as APAC and DBMAS.
It's very high, and I think it goes unnoticed a lot, undiagnosed, and you don't find it out until it's too late. It's too late to not so much fix, but help them cope with it, and it's just too far down the track. The 2 main issues in aged care are depression and managing what they call challenging behaviours of concern associated with dementia. There are a lot of misconceptions in regards to depression and the elderly. A lot of people believe it's normal for elderly to be depressed, and that's a misconception. They also, a lot of people have misconceptions around depression generally. They think it's something that can be, that can be willed away, or you can be stoic and try and overcome it yourself. Self-report is unreliable. We know from our figures that over 50% of residents slip through the system. Some are diagnosed and monitored, but a lot slip through the system. And so we're trying to improve the skills of staff to detect it by looking at observable signs rather than reportable, because they will never report it. They think it's a stigma, they think it's a failing, they're afraid that they're going to be moved. There are a lot of reasons why the elderly won't say they're sad or they're worried. So we're sort of improving the observational skills of staff to detect their concerns and to better manage it, and using more tailored approaches. You pick up on the signs of mental health, like the loss of appetite and the sleeping, but I don't think at the start you really put that with depression. So I think learning what those signs are, and then in your head realising that they are the early signs of depression, I think that's what's going to catch on quite quickly. It's more just finding it early and getting people on the right path, and it's not just the depression, it's the challenging behaviours, trying to work with those earlier on so the behaviours don't extend and create more work for the staff and other residents. I think it's going to make our work a lot easier in the end.